We are running short of time. We are going to the next speaker, Dr. Maulik from India. His presentation is TAVR, My Journey, My Learning.
Okay, so are my slides visible?
Yes, make it, yes.
Yeah. Okay.
Yeah,
So I will skip the initial part of the presentation because Dr. Nasir has done an extremely good job, and I don't have to harp on any of that. So I'm starting my timer now, and okay. So we all know that USFDA has approved TAVI valves for extreme risk, intermediate risk, and low risk in these months. So this is, I think, what Dr. Nasir already discussed, and I mean, I'll just go to the cases. So this is a elderly patient with a regular garden variety aortic stenosis, 78-year-old gentleman, COPD, cancer survivor, NYHA class 2 symptoms, severe aortic stenosis on the 2D echo, otherwise are normal LV function. So he's a good candidate for both, but because of age and because of the patient's preference, decided to go for TAVR. So for TAVR, the most important part is CT scan. CT scan is kind of a 80% of the TAVI is CT scan. 20% is just executing what you have decided on the CT scan. So CT scan will tell you the approach, the access, the coronary issues, the annular sizing. So this is the case which we did with the Evolute Pro valve, where you decide the valve size by the perimeter, which is 65.1, which is suitable for a 26 millimeter Evolute valve. So you can see it's a tri-leaflet tricuspid aortic stenosis. You can see the hockey puck appearance and the calcification. And these are the other pictures of the aortic arch. The LV is a small cavity, hypertrophied. Angle looks okay. So this is the first step. In the first case, I'll go through the steps because I think it's important that everybody sees the steps of the TAVR. So you see, we decided to do TAVR from the right side. So from the left side, you put a puncture, put an internal mammary artery catheter, take the picture, then puncture the right side, put a 7 French sheath, put 2 proglides, and then dilate it with a 10 French. And then this is a 14 French sheath or 16 French sheath as per the choice of the valve, going across the femoral and iliac system. This is a coplanar view where all the 3 cusps are in the same line. And in the coplanar view, we are taking an angiogram. So here in the right side picture, we have one pigtail. So we have crossed the aortic valve with an AL1 or a AR2 catheter of your choice. With a Terumo wire, you can cross the aortic valve. And in this picture, we have the one pigtail in the aorta, another pigtail in the LV. You do the hemodynamic study and pressure difference and everything. You also check the loading of the Evolute valve, whether it is loaded symmetrically and whether both the paddles are in the paddle sockets or not. Then this is the valve, which is still in the capsule, going across the aortic arch, how smoothly it passes. This is in the LAO picture. This is how you position the valve. The lower dark band, which is the head marker or the capsule head marker, you have to position it. I mean, the final depth of the deployment of an Evolute valve is between 2 to 5 millimeter below the annulus. So that's the recommended IFU depth. This is at 80 or 90% deployment. The valve is partially open, but still completely retrievable and recapturable. Here, the pressures are back. The valve is open. You can wait here and see whether you want to put any more, whether you want to recapture and readjust your depth. And this is how you finally release the valve. This is being released under rapid pacing. So this is how you release the valve. And this is how it sits in the position. So this is the final picture, perfect depth, no PVL. And this is the groin picture after the proglide closure. Good hemostasis, good distal flow. So this is a garden variety aortic stenosis case of a tri-leaflet tricuspid aortic stenosis and TAVR. Second subset, this patient had to start with had a aortopathy with a bicuspid aortic valve, underwent Bental procedure and aortic valve replacement with a tissue valve. Now she's 80-year-old. Bentals was done with an aortic root replacement, and there is a 21 mm Magna valve. Patient has atrial fibrillation and interventricular conduction defect. This valve is degenerated. It is causing severe low flow, low gradient aortic stenosis, confirmed by dopamine echo. EF is 35%. She becomes a moderate or intermediate risk candidate. So naturally, the choice was TAVR, valve-in-valve TAVR. So this is the CT scan picture. CT scan will tell you, you can see the proximal graft here, the mental graft on the left side image. The middle image is showing the cropped out picture of the tissue valve, magna, which is degenerated. And the extreme right image is showing the valve to coronary distance. So whenever you're doing a valve-in-valve TAVR, most important is to avoid coronary occlusion, because the old leaflet are going to stand up when you put a new valve, and they may occlude the coronary origins. So the distance between the virtual valve, just raise the valve frame at the level of coronary height, and like as a cylinder, and see what is the distance between that cylinder and the coronary origin. If it is more than 4, you are laughing, and you most likely the coronary occlusion is not going to be an issue. There is an app. So which valve to put in a which valve? So the surgeon, Dr. Vinayak Bapat, or Vinny, has designed this beautiful app where you can put the previous valve size and the type, and it gives you what new TAVI valve you should put. It's called Aortic Valve-in-Valve app. It gives you such beautiful pictures also, that how the old valve will look, how the new TAVI valve will look inside the old valve, and how the fluoroscopic picture of the both will appear. So it's a beautiful app. They've done a lot of hard work on that. So this is a TAVI in this Bental patient. You can see the first root angiogram and see the degenerated valve. This is the stiff wire going inside the LV. One pigtail is in the aorta and one pigtail is in the LV. We are adjusting the depth, releasing the valve. This is at the picture. The right side picture is at the 80% release, but the depth is ideal, and we are happy to release. And this is the picture where we release the valve. So this is the valve being released. This is a valve-in-valve procedure in a Bental patient. And this is the final result. No PVL, good result, no gradients. So this was about post-Bental TAVR. Then there's a bicuspid. Not shooting the time. Yeah, okay, I have time. So there's a bicuspid aortic stenosis. 75-year male avoiding surgery for last 2 years because of lockdown. EF 35%. This is a patient who has annular as well as LVOT calcification chunks. See the top left and top upper and lower images, and this is a type 1 bicuspid. So this patient, you would not be wanting to put a balloon expandable valve because you might rupture the annulus or injure the LVOT. And this patient, we have put this, I'll not go through the steps. This is the balloon picture where we are dilating the valve with the balloon, pre-BAV. And this is the valve release picture. And this is the final picture. Very well expanded frame with less than trivial paravalvular leak. Very good result. We have 6 months follow-up now. Good result and mean gradients of around 6. Rheumatic heart disease and TAVR. This is a 69-year-old patient who is a known case of rheumatic heart disease, has undergone 2 previous mitral replacement surgeries, and now has severe aortic stenosis, most likely of rheumatic origin. So you can see the metallic valve leaflets moving here. So we cross the valve. This was a little complex case because we had to use a snare to internalize the system towards the inner curvature, but I will not go into that detail of that and those complexities. So this is the valve being released. There was still some inflow narrowing. So we post-dilated the valve with a 20 mm balloon. And this was the final result. Metallic valve functioning well and TAVR valve sitting very well in the aortic position. This is the most sickest of the patient and probably my last case. Patient is a 62-year patient, has undergone a tissue bioprosthetic surgical aortic valve replacement in 2015. He comes with advanced shock, cold, edematous, hypotensive, hypoxic, angiography done outside somewhere, no coronary artery disease. 2D echo shows severe MR, moderate gradients of AS, no paravalvular leak. So basically degenerated valve, normal LV function, dilated RA, dilated RV, severe RV dysfunction, and severe pulmonary hypertension. Patient is in the ICU now, high inotropes, on dialysis. Because of congestion, there is a coagulopathy with PT-INR of 3. CT pulmonary angio was done to rule out pulmonary embolism because nobody was able to fathom the right side failure. Day 2, patient is still negative balance, but still very high inotropic support required, complete renal shutdown, worsening coagulopathy. At this point, we offer TAVR to the family. They agree. Now, what are the challenges for this TAVR? We don't have a CT scan and patient is not fit enough for a CT. So we extracted the TAVI information from the CT pulmonary angio. We don't know the previous valve size or type. So the outside coronary angiography showed a valve image. And based on that image, we decided that it's a Paramount Magna valve. Patient, there is no urine output. So plan was to do minimum contrast. INR was 3. So high risk of bleeding. So do it under vitamin K and plasma cover. Patient was in profound shock. So our bailout plan after TAVI was to put an ECMO post TAVI if the patient doesn't come off. And there is a very small window. So we decided to do it on the same day.
Hello. Hello.
And so general anesthesia, TEE, we decided to do TEE. We do all our cases under conscious sedation. We don't do GA, but in this case, we wanted to do TEE because we wanted to minimize the use of contrast. So plan was to put a 26 evolute in the Magna 23. I will just go to the final pictures. And this is the final TAVR picture of a valve in valve. Just see the hemodynamic improvement. This is pre and this is post. Gradient pre, gradient post, gradient of 6 millimeters, peak to peak, pre, while, the post gradient and the pre gradient was around 55. And see the hemodynamics. Patient was on 3 inotropes before the TAVI. At the end of the TAVI, we were off NORAD, vaso, only small dose of Adri was remaining. Cardiac output increases from 3.1 to 5.4. Central venous pressure reduces from 30 to 11. SVO2, mixed venous saturation from 50 to 75. LVDP from 20 to 9. Peak to peak gradient from 56 to 6. No AR. And TAPSE, which was 8 earlier, becomes 15 on post-op day 3. So this is the patient on day 5 going home. And it was a very well published this thing. Patient is now, if you have completed 1.5 years, patient is doing very well. And this, somebody has told me that they wanted to see a MyVal case. I have 2 minutes left still. So this is a MyVal, Indian valve. And this is the result. I will just go through the result part. It's a balloon expandable valve. Thank you very much. I still have 2 minutes left.
Hello.
Yeah.
Dr. Maulik Parekh, I'm very much pleased with your headline of the lecture, your journey and your learning. Actually, it is very, very charming one, what you have described in your journey.
Yes, sir. Thank you so much, sir. Tell me.
In the cases of TAVI, and what are the problems, that is complication you have faced during a series of patients with TAVI?
So the commonest complication when you are starting the TAVI program is going to be groin, because you may not be very proficient with the usage of large bore sheaths and vascular closure devices like a ProGlide or an ProGlide plus AngioSeal. So we have had a couple of instances where we needed to kind of open and close the femoral dissection or something. That was one. And rarely, as per the literature, I mean, we have had 2 or 3 cases where patient required pacemaker. And so these are the basic problems. So
is there any coronary problem?
No, till date, we have not faced a coronary issue. We have had to use coronary protection for a couple of cases and also do a chimney procedure for one of my patients, which was obviously a high-risk patient, but not had any coronary occlusion till date, touch wood, because coronary occlusion on table is almost certainly fatal, because there is no way that after TAVI valve deployment and the coronary that is occluded can be recannulated and salvaged unless the God is really with you.